This video describes adductor canal catheter insertion for total knee replacement surgery using a Pajunk E-Cath catheter over needle kit. First, a quick introduction to the Pajunk E-Cath. This is a catheter over needle system. It starts with the insertion of an introducer cannula with an inner stylet. And this looks like an intravenous cannula with the inner stylet needle protruding slightly beyond the introducer cannula. The inner stylet functions just like a block needle. And just like any single injection block, the needle tip is placed in an appropriate perineural location, and the initial bolus injection is performed through the inner stylet to achieve spread. Once this has been completed, the introducer cannula stays in place, and the stylet needle is withdrawn and replaced by an inner catheter. This is the E-Cath, and this is used for subsequent injection. It should be noted that the tip of the standard E-Cath extends beyond the introducer cannula only as far as the tip of the needle stylet protruded. The main advantages of the E-Cath over the more traditional catheter through needle system are: first, it's a simpler system and thus easier and faster to insert. And second, there's less risk of local anesthetic leakage at the insertion site, as the tissue tunnel is more snugly occupied by the introducer cannula. It does have certain limitations. The introducer and catheter for the E-Cath system are of fixed lengths. They do come in a variety of lengths, and thus it's important to choose the right one for your patient population and the specific block that you're doing. Second, the catheter tip, as I mentioned, can only be advanced a fixed distance beyond the cannula tip, and essentially the end of the catheter will sit where the stylet needle tip was positioned. Now, with catheter through needle sets, many of us are used to being able to advance a good length of catheter beyond our introducer needle into the perineural space to thus minimize the risk of dislodgement and malposition. This isn't possible with the E-Cath, and thus these 2 points somewhat limit its flexibility of use. For this reason, I don't use the E-Cath in all my nerve blocks, but where I do, I've adapted my technique to take these limitations into account. More recently, a version called the E-Cath Plus catheter was introduced to help address the risk of dislodgement. The inner cannula of the Plus version extends 15 millimeters beyond the tip of the introducer cannula. This is shown here. Note, however, that this is again a fixed distance. If there's any obstruction preventing the catheter from extending this distance, you will not be able to lock the catheter and introducer hubs together. So it's critical that there is sufficient space beyond the stylet needle tip for the catheter to advance into. And generally, we create this by hydrodissection without loading bolus of local anesthetic. For preoperative insertion of an adductor canal catheter, the oblique approach that I've described in other videos lends itself well to the E-Cath. The skin entry site for needle insertion should be a generous 2 hands breadth above the patella and above the midpoint of the thigh, so that the catheter hub and dressing remain well out of the way of the surgical drapes and thus will not be accidentally pulled out when the drapes are taken down at the end of surgery. We've not had issues with the catheter lying under the thigh tourniquet, as long as the hub is padded with something like an EpiGuard dressing. Although I'll also note now that many of our surgeons do not routinely use or inflate the tourniquet for total knee replacements. With this oblique approach, the introducer cannula and the catheter can be inserted 2 centimeters or more into the adductor canal to lie superficial to the artery and draping over it with the tip on the medial side of the artery. If the E-Cath Plus is used, which is my current preference, this provides an additional 1.5 centimeters of catheter length within the canal, thus further reducing the risk of malposition. Postoperative insertion may be preferable if your operating room workflow and staffing allows for it. The approach is a little more straightforward, as there's no need to plan the insertion site and trajectory to stay out of the surgical field, and it avoids risk of intraoperative catheter dislodgement from surgical manipulation of the knee. The basic steps of catheter insertion, though, are the same, which I'll now describe in more detail. Start by preparing the equipment. Here's a list of items that I currently use in my institution. It will differ depending on your context and environment. And once again, the appropriate E-Cath set in terms of length and whether it's a standard or plus version should be chosen based on the body habitus of the patient. As part of preparing the catheter set for use, you should familiarize yourself with how to disengage the stylet needle from the introducer cannula. First generation E-Caths require the stylet hub to be rotated 90 degrees to disengage from the cannula hub. Newer E-Caths have different hub designs, and some may require an unscrewing motion of a full turn or more, as shown. Attach the supplied filter to the hub of the catheter tubing and flush the entire assembly clear of air. In a similar fashion, attach your loading bolus of local anesthetic to the tubing connected to the introducer cannula and stylet needle, and the entire kit is now ready for use. Contrary to what is often taught when performing adductor canal blocks, note that there is absolutely no need to flex the patient's knee or to force the patient into an exaggerated frog leg position. The operative leg can be slightly abducted and externally rotated if comfortable for the patient, but otherwise the anteromedial thigh is perfectly accessible with the patient in a supine straight leg position. Disinfect the skin over the anteromedial thigh accordingly and apply sterile drapes to create a generous working area. In this case, I'm starting with an adhesive plastic drape that's supplied in our regional anesthesia block tray set. I take advantage of the adhesive and stick it to the lateral thigh so it doesn't fall off. The square draping is then completed with 3 sterile towels. Apply a small amount of gel to the patient's skin and perform a scout scan to identify the superficial femoral artery lying under the sartorius muscle in the adductor canal. My personal preference with regard to the level of insertion along the adductor canal is to enter the canal in its distal portion. I identify this by sliding the probe distally towards the knee until the artery drops away from the sartorius muscle, and then I slide it proximally so that the artery rises again to just contact the sartorius muscle. This distal level of injection minimizes the risk of inadvertent quadriceps weakness from proximal spread of the injectate to the motor branches of the femoral nerve, both from the initial loading bolus as well as my infusion. At the same time, I find there's always enough proximal spread to reach the nerve to vastus medialis, as we see here in this post-injection scan from a different patient. Rotate the probe to bring the lateral edge more cranially and to obtain an oblique view of the canal. The artery and the muscle will elongate in appearance. Shift the probe laterally to visualize the lateral corner of the sartorius muscle where it meets vastus medialis. Perform local anesthetic infiltration at a skin insertion site 2 to 3 centimeters away from the edge of the probe while ensuring that the E-Cath that you've selected is long enough to reach the artery and the canal. In larger patients, and particularly if I'm using a shorter E-Cath, you can also use the E-Cath itself as a makeshift ruler to ensure that it is indeed long enough to reach the artery and the adductor canal from your planned skin insertion site. Insert the needle with a steep initial angle to pierce the skin, and then adjust the needle trajectory as needed. As I've said, the aim is to pierce the lateral edge of sartorius muscle and travel along the fascial plane that separates sartorius and vastus medialis. Avoiding an intramuscular path through sartorius minimizes the risk of catheter dislodgement from contraction of the sartorius muscle when the patient bends their knee during postoperative mobilization. Hydrolocation helps to determine needle tip position and also creates a safe path for the advancing needle tip. Aim to contact the superficial or 12 o'clock aspect of the artery. Survey the area during injection to identify and avoid the saphenous nerve. Non-active fluids such as normal saline or 5% dextrose can be used for initial hydrodissection. But once I'm satisfied that the needle tip is within the adductor canal, I switch to injecting the loading bolus of local anesthetic. To establish the block, and open up the space within the adductor canal. I often advance the needle as my assistant performs a slow bolus injection. This simultaneous injection plus advancement creates a safety cushion of fluid ahead of the needle tip, which pushes aside any vulnerable structures and minimizes the risk of mechanical trauma. I also dynamically scan with small sliding motions to assess the spread pattern during local anesthetic injection. This ensures that the needle tip and the injection spread is truly within the canal and not outside of it, and also that there are no nerve structures at risk. The needle tip should be advanced to the medial border of the artery or just beyond to maximize the length of catheter that lies within the canal. I do not try to advance further beyond what appears to be the boundary of the compartment. The vasoadductor membrane overlying the artery is thick and multi-layered, and it can be tricky to try and pierce it when you're close to the artery. It's best to pierce and get deep to the vasoadductor membrane while the needle tip is still quite lateral and far away from the artery. If you're struggling to flatten the needle and its tip so that it's not pointing directly at the artery, it can be helpful to release the downward pressure being applied through the probe. This is often an unrecognized factor that's pushing the needle tip downwards. If the tip of the needle tip is in the correct compartment, injection of a large bolus of local anesthetic will also create space and push the artery downwards out of the way. Hold the needle steady, even applying some forward pressure to keep the tip in position as you carefully lift the probe off. Withdraw the stylet smoothly, taking care not to let the introducer cannula bend or otherwise move out of position. Controlled pressure to keep the tip in position within the canal is especially important in larger patients with a lot of overlying mobile soft tissue. The cannula can be even gently advanced as the stylet is withdrawn, just as long as there is no resistance or tactile signs that the tip is kinking. This can help to keep the tip in place as the tissues are allowed to rebound into their resting position as everything is released. Insert the fluid-primed inner catheter and thread it into the introducer cannula. There should be no resistance to advancing it up to the hub of the introducer. If there is resistance, the introducer cannula tip may be kinked. If so, carefully withdraw the introducer slightly to see if this solves the problem. Ultrasound imaging is then used to verify catheter placement, and test injection is performed to verify spread within the compartment. Arterial compression with injection is again a useful confirmatory sign. The adductor canal E-Cath can also be placed postoperatively in the recovery unit. As mentioned earlier, if you have the time and opportunity, I do consider this preferable as it avoids any conflict between the surgical field and the catheter insertion site. It also avoids the risk of dislodgement from intraoperative surgical manipulation of the knee. It's somewhat simpler to perform as there's no need for an oblique needle trajectory, and the adductor canal can be targeted with the probe in the usual transverse orientation. It's still important to avoid inserting the catheter through the sartorius muscle. As we've mentioned, contraction and extension during mobilization will tend to pull the catheter out of position. So hydrodissect the needle trajectory that starts at the lateral edge of sartorius and travels under the deep fascia of the muscle towards the adductor canal. Once again, target the 12 o'clock aspect of the artery and advance the needle over the superficial aspect of the artery, hydrodissecting a safe passage. Needle tip entry into the correct compartment is signaled by local anesthetic injection that outlines and even flattens the artery. The stylet is then withdrawn from the introducer cannula, the inner catheter inserted, and catheter tip position again confirmed by imaging the spread of a small amount of fluid injection through the catheter. The most important part of any peripheral nerve catheter insertion is the fixation and dressing of the catheter. This will minimize the risk of dislodgement during surgery if placed preoperatively, and if done with appropriate care, the catheter dressing will also remain secure and intact for days afterwards, even when patients are sent home. Start by ensuring that the site is as clean and dry as possible. Tissue glue is probably optional with the E-Cath given its catheter over needle design, but it does provide added security against backward leakage of fluid that might otherwise compromise the dressing. Create a plug of glue at the entry site and let it dry. An EpiGuard fixation device is applied for all catheters in our institution and is particularly useful for the E-Cath. A similar dressing is also available from Pajunk. Position the foam pad of the dressing under the hub to protect the skin against pressure injury. Apply a small Tegaderm dressing to cover the EpiGuard. A second overlapping Tegaderm can be applied if needed, but the aim overall is to keep the footprint of the dressing as small as possible. The key to keeping the dressing intact is to secure the edges of the Tegaderm with strips of 3M micropore paper tape, as I demonstrate here with a different catheter set. Make a window frame with the tape, and take care to ensure that the edges of the paper tape are completely flat and adherent to the skin, as well as being wrinkle-free. Finish by wiping the paper tape with an alcohol swab. As the alcohol dries, it makes the paper tape adhere extremely well to the skin, even if it subsequently gets wet. Secure the remaining catheter length to the skin, either with multiple small Tegaderms or with micropore tape and alcohol. I prefer tape for durability. Fix the catheter filter to the lateral aspect of the lower abdomen in a location that will not cause discomfort when sitting or pressure from the waistband of trousers. A filter fixation device is supplied in the kit. However, I will say that the filter tends to pop off the holder quite easily, and if you send patients home with a catheter, they should be educated on how to clip it back in place.